The first goal of the procedure was to see that we could in fact transmit acoustic energy precisely and with enough intensity to cause a thermal ablation. Here you can see some of the earliest images where the lesions were accurately made, and that the lesions change in time as they mature. And for the group, you can see some of our technical parameters where an average of nearly 18 sonications was delivered for each of the patients. These are incremental increases in the acoustic energy. The mean final acoustic energy achieved was 10,000 joules for brief durations of 10 to 12 seconds. And peak voxel temperatures at the focus were achieved at nearly 60 degrees, and tissue was ablated. And as I alluded to, the volumes of the lesions change in time as the lesions mature or evolve. You can see that the lesion volume is largest really at 1 day, and then starts to diminish as the lesions coalesce, with smaller volumes at days 30 and 90. And the lesions behave very much like an ischemic infarction. This was we very carefully characterized the MR characteristics of the lesioning process, just like has previously been done with radiofrequency lesioning. And you can see that the earliest changes that you would typically see would be on diffusion-weighted imaging, like an ischemic infarction. And within a few minutes, you can see T2 changes, and then T1 changes take a little bit longer. We always saw susceptibility-weighted changes, which were indicative of blood products, but we saw no real overt hemorrhages at with any of the patients. And we also went back to the laboratory to try to characterize the histologic behavior of the lesions. And here you can see thalamotomy lesions being made with different modalities, focused ultrasound, radiofrequency, and ionizing radiation or stereotactic radiosurgery. And basically, focused ultrasound lesions behave very much like radiofrequency lesions in that they're both thermal ablations. You tend to see vacuolization and axonal swelling acutely as the infarction occurs, and then macrophages enter the lesion at around 48 to 72 hours. We start to see gliosis within a few days, and then the lesions coalesce into a cyst and collapse with time. And this is a much different histological evolution than you see with ionizing radiation, where the infiltration of macrophages can be much more dispersed or broad beyond the lesion. And so thermal and radiation lesions behave much differently. With thermal lesioning, the effect is immediate. Radiation lesioning, the effect is delayed or latent. It's difficult to monitor radiation lesioning, and then there's the issue of repetitive radiation lesions where there's some tolerance to how much the brain can take as far as radiation dose. Jean-Francois Aubry attempted to simulate our experiments with radiofrequency, focused ultrasound, and radiosurgery. And you can see that this graph nicely depicts the difference between thermal and radiation dose, where the drop-off is much sharper with thermal lesions than with radiation lesions. And so after several pilot studies around the world, at our institution and in Toronto and Korea, successfully showed that focused ultrasound lesions could be precisely made in the ventral intermediate nucleus of the thalamus for patients with essential tremor. A larger international multi-center study was organized and really much more definitively showed the efficacy and safety of focused ultrasound thalamotomy for the treatment of essential tremor. And these are the results of the primary outcome variable from the clinical trial. You can see that the mean scores or the group scores are illustrated on the left, where the focused ultrasound thalamotomy dropped tremor scores or improved tremor significantly over sham procedures. 1/4 of the patients were randomized to a sham procedure, and then later on could cross over and have the treatment once the blinded phase of the study was complete. The individual scores are shown on the right, and you can see that in the active treatment or blue labeled bars, almost all of the patients had some type of improvement. The overall improvement at 3 months was a median of 47%, and the sham patients shown in the red really didn't have as much improvement, and this was highly statistically different between the groups as the primary outcome. And this is an illustration of the effect that you would see with a focused ultrasound thalamotomy. This is a patient with essential tremor. She doesn't have a resting tremor like you would see with Parkinson's disease, but she does have a lot of postural tremor where the tremor is evident with certain positions of her hand. And she also has an intention tremor, so that as she tries to use the hand, she develops tremor, or the tremor manifests more with different types of intention maneuvers. And we put the patients through different tasks to try to rate the tremor or the intention component. Here's a drawing task which nicely illustrates the disability that can arise with essential tremor. And you can see after the procedure at 1 year, the tremor is nicely treated. There's no postural tremor with the outstretched position of the hands. And there's no intention tremor either. And this is a patient, obviously, that's had a very good result. The spiral drawings and the handwriting samples nicely illustrate the difference between baseline tremor level with essential tremor and the alleviation of the tremor after the focused ultrasound thalamotomy. You can see the pouring task is nicely improved also. And so it's important with every procedure to carefully characterize any potential side effects that can occur. This was a clinical trial conducted in 76 patients. It was FDA monitored, and so we really captured every type of adverse event, whether it was related or unrelated to the procedure. And we've listed these in our manuscript in the New England Journal. Here you can see that the most common side effects were those that are typical of a thalamotomy procedure or thalamotomy ablation, where there can be some sensory or cerebellar side effects which are closely related to the ventral intermediate nucleus of the thalamus or the tremor target. And you can see it was very common to see sensory disturbance like numbness or tingling in the fingertips or the lips. This occurred in 38% of the patients and persisted during the 1-year study in 14% of the patients. Only one of these sensory phenomena was scored as a serious adverse effect or an uncomfortable side effect or numbness, dysesthesia type of sensation. We would see gait disturbance or unsteadiness also as a cerebellar type of deficit with these thalamotomy ablations. Most of them all resolved, but you can see that it persisted in 9% of the patients. 5 patients required physical therapy during the trial, and 1 patient did require an assist device. Otherwise, the side effects tended to be mild or temporary. There were no hemorrhages, no infections, and no cavitations, which is a side effect unique to ultrasound procedures. Most importantly for the patients, alleviation of the tremor leads to big improvements in quality of life and the disabilities that patients experience in their day-to-day activities. Here you can see two types of validated ratings for essential tremor. The quality of life questionnaire in essential tremor was administered to all of the patients. These are self-reported quality of life scores that improved overall roughly 60% or so. And also disabilities or the tasks that patients experience in day-to-day life improved significantly as well. And so focused ultrasound has been approved for essential tremor in several countries now. And obviously the next consideration would be Parkinson's disease, which is a similarly related movement disorder condition, although more complex. I think it's important to point out that the real goal for investigators and patients with Parkinson's disease is to find a cure. It's a much more disabling condition, and it's a widespread neurodegenerative condition of the brain. So a curative procedure or a protective procedure would really be the ideal goal that I think we'll achieve someday. All of our treatments today, medically and surgically, are aimed towards symptom relief. And so we think that focused ultrasound could be a very nice adjunct for symptom management in Parkinson's disease. And there are different symptoms that occur during Parkinson's disease depending on how it affects the brain. Some patients have tremor, some patients have bradykinesia and rigidity more so, or gait disturbance, and some people also develop side effects related to the therapies or the medications that are administered, like dyskinesia and motor fluctuation disorders. So there have been several different clinical trials that have been initiated and are underway, aimed to treat different areas of the brain to manage the different types of symptoms. Our group and the group in Israel have performed ventral intermediate nucleus thalamic ablations like we demonstrated in essential tremor for the management of Parkinson's tremor. In Zurich, the palliothalamic tract has been lesioned to successfully manage motor conditions seen with Parkinson's disease. And these treatments that were performed seem to be dose-related, so that larger ablations achieved more of an effect than the smaller ablations. The globus pallidus has long been known to be a nice target to manage dyskinesia or hyperkinetic symptoms that you see with medication or chronic levodopa management. And this has been trialed in Korea and Toronto, and there's now a large randomized controlled study being organized internationally to study this further. And then in Spain, Jose Obeso and his team have made subthalamotomy ablations in an early phase pilot study for the management of motor symptoms of Parkinson's disease.